Good afternoon, everyone. Our next topic is the physical examination of the heart. Along the way, we're also going to tackle a little of the anatomy and its physiology. Listening to the heart is the epitome of bedside diagnosis. It's actually a clinical skill, one that you're not going to learn, not with lectures and not with OSCEs, but with actual patient experience. But I'm here right now to introduce to you some of the concepts involved during the physical examination. So in order to master this, you need to do it during your clinical rotations. And actually, there's a documented decline in physical examination skills in all levels, from students up to actual doctors. Okay, but at the end of the day, the cardiac examination follows the usual format: inspection, palpation, percussion, and auscultation. That's what we're going to learn today. But first, we have to review the anatomy of the heart for a bit. Okay, so the heart is like an inverted, asymmetrical triangle. And of course, narinig natin yan in popular media na nasa may bandang left siya. But it's more complicated than that, right? Okay, so you need to be able to visualize the position of the heart. So for example, in physiology, you have this simplified diagram, right? Right atrium, right ventricle, left atrium, left ventricle. But in anatomy, we know it's more complicated than that because the left atrium is located posteriorly. And most of the anterior cardiac surface is actually the right ventricle. The right border of the heart here is the right atrium, while the left border is made up mostly by the left ventricle. Also, the left ventricle is located more inferiorly. So it's complicated, right? Alright. But what you have to remember is that most of the anterior cardiac surface is made up of the right ventricle. So, the right ventricle is connected to the pulmonary arteries, right? And here, around the angle of the sternum, it's called the base of the heart. Kaya nga siya inverted triangle. Okay? While the left ventricle sits behind the right ventricle, forming the left lateral margin. Also, the left ventricle forms the apex of the heart. Right? So kung may base, meron siya ding apex. Kaya nga siya inverted triangle. Okay? So the tapered inferior tip of the left ventricle is called the cardiac apex. It forms the apical impulse, and you could palpate for it, known as the point of maximal impulse, or the PMI. The PMI is located in the fifth intercostal space, just medial to the left midclavicular line. What's the midclavicular line? So you take your clavicles here, find the middle of that, draw a line, a vertical line, then that's your left midclavicular line. Okay? The point of maximal impulse is located just medial to it. So the heart has 4 chambers, 2 atria, left and right atrium, and 2 ventricles, left and right ventricles. And there are also 4 valves to ensure that blood flows one way, to ensure that it flows correctly. Of course, if you have any abnormalities in that flow, it's going to lead to a murmur. Okay, that you will listen to during your auscultation of the heart. Alright, so 4 valves, and we could divide them into 2. The atrioventricular valves, which are located in between the atria and the ventricles, and the semilunar valves, which are the ones that control the blood coming out of the ventricles. Okay, so the 2 atrioventricular valves are the mitral and the tricuspid valves. So the mitral valve is located in between the left atrium and the left ventricle. That's the mitral valve. While the tricuspid valve is located in between the right atrium and the right ventricle. The semilunar valves are the aortic and pulmonic valves. So it's obvious from their name which structures they lead to. So for example, the aorta, the aortic valve, which controls the outflow of blood from the left ventricle to the aorta, is called the aortic valve. While the pulmonic valve controls the flow from the right ventricle to the pulmonic trunk. Right. The semilunar valves are called semilunar because their leaflets are shaped like half moons. Right? Aside from anatomy, we also have to quickly review the cardiac physiology. Let's review the cardiac cycle. So there are 2 phases, right, during the cardiac cycle, systole and diastole. Systole is the period of ventricular contraction. So this graph here shows the pressure inside the left ventricle. So during systole or during contraction, left ventricular pressure rises from less than 5 millimeters mercury up to around 120 millimeters mercury. Okay. So, ano nga ulit yung valves na involve yung left ventricle, di ba? The mitral, as well as the aortic valve. So, during the start of systole, when left ventricular pressure exceeds left atrial pressure, the mitral valve closes. And the first heart sound, or S1, corresponds to the closure of the mitral valve. Okay? Eventually, as the contents or the blood that's coming from inside the left ventricle is expelled or naubos na yung nilalabas na blood from the left ventricle, eventually, mag-start na siyang bumaba. And once the aortic pressure exceeds the left ventricular pressure, the aortic valve is going to close. And when that happens, that's called the second heart sound, which corresponds to the closure of the aortic valve. Right? So, remember that, systole and diastole. And S1 and S2 corresponds to the closure of the mitral valve and the aortic valve, respectively. So again, these are the two heart sounds, S1 and S2. We have focus on the left side of the heart. That's because mas malakas siya because larger pressures and larger volumes are involved. Okay? However, technically, pareho naman siya pwedeng marinig, no? So sa right, ang counterpart nung so diba, kung yung S1 corresponds to the mitral valve, while S2 corresponds to the aortic valve, closure ng aortic valve, ang counterpart niyan sa right side is yung tricuspid valve as well as yung pulmonic valve. Okay? Take note, S1 is usually louder than S2 at the apex, while S2 is louder than S1 at the base. Okay? And malaman nyo later na pwede palang normal na marinig mong magkahiwalay yung tunog ng S1 at S2. So this is the physiologic splitting of S2. Meron din bang physiologic splitting ang S1? Meron din. But the mitral valve is much louder. Kaya mas mahirap siyang marinig. And marinig mo lang yung splitting ng S1 in certain areas of the heart. So you're going to more likely encounter the physiologic splitting of S2. And when can you hear it? You're going to hear it during inspiration. So pag breathe in mo. Why? Because there is going to be increased venous return to the heart. Kaya nade-delay yung pagsara ng pulmonic valve relative to the aortic valve. Okay? So the two components you're going to hear are the A2 and P2. But during expiration, what should happen is that it's going to fuse into a single S2 sound. So kahit pag-expire hindi nawawala yung splitting na yon, ang maririnig mo ay fixed split. Yon ay abnormal na. Okay? You're going to hear the physiologic splitting best at the second and third left interspaces. Aside from physiologic splitting, you could also hear extra heart sounds. So ito, iba talaga siya from S2. So meron tayong S3 and S4. So yung S3, it could be normal among younger patients. So among children and young adults, it's normal. But for those who are older than 40 years old, it's usually abnormal or pathologic. It could indicate heart failure or volume overload. S3 is an early diastolic sound coming from rapid deceleration of blood against the ventricular wall. Okay? So, ang tunog niya is Kentucky daw. Kentucky. Or trug-tug. Or tug-trug. Yung pangalawang sound yung tama. And yung other one is S4, also known as atrial gallop. Okay? So it's a late diastolic sound marking an atrial contraction against a stiff ventricle. This one is always abnormal. It's a sign of ventricular hypertrophy or fibrosis. So yung S4 immediately precedes S1. So ang sound niya is Tennessee or turug-tug. Okay. So aside from heart sounds, you could also hear 4 murmurs. So murmurs are distinct sounds caused by turbulent blood flow. Usually, if you have a murmur, it's usually diagnostic of a valvular heart disease. They are distinguished by their pitch and longer duration compared to S1 and S2. So hindi lang siya parang tibok, no? Iba yung tunog ng murmur. And when you have a murmur, it could be either of two things. could be either because of a stenosis or regurgitation. Stenosis means that the valves are narrowed, meaning the forward flow is obstructed, while regurgitant means that the valve fails to close fully. Because of that, there is backflow or backward flow, also known as retrograde or regurgitant flow. So, in order to, so there are many different types of murmur that you're going to learn throughout med school. But in order to describe them properly, you need to note the following things. The timing. Is it closer to systole or closer to diastole? How about the duration? Shape, meaning does it grow stronger, or is it more continuous? The location of maximal intensity, radiation intensity, and even the pitch and quality. Okay, in the next slide, we're going to learn about the different auscultation areas. Okay, so when you hear a murmur, you need to describe where you hear it. So there are different areas corresponding to our different valves. So the mnemonic is APTM, or always pray to Mary. So for Catholics, it's easier to remember that way. Okay, but how do we isa-isahin natin? Paano ba siya, ano ba yung mga areas na yon? So merong 4 na valves, so 4 din yung areas. So the aortic valve is closer here to the right sternal border, but take note, it's larger than that, no? It overlaps with the others. For the pulmonic, is located here on the left side. Tricuspid on the left sternal border, and mitral closer to the apex. Next, I'm going to introduce to you the concept of the ECG or electrocardiogram. Don't be confused, this is different from the 2D echo. The 2D echo is an ultrasound technique. No? Okay, so this one is an ECG. Essentially, we're measuring the electrical pathway. Remember from physiology, there's an impulse, electrical impulse, starting from the sinoatrial node or the pacemaker node. It then travels to the AV node, located in between the atrium and the ventricles. Then it travels down the bundle of His, then eventually to the rest of the ventricular myocardium. So that's what we're measuring with the ECG. And you measure using various leads. Okay? So you have 2 types of leads, limb leads and precordial leads. So precordial meaning placed on the chest, while limb leads meaning placed on the limbs, the hands and the feet. Okay? So there are 3 limb leads. These are the AVL, AVR, and AVF. Okay? And there are also precordial leads from V1 up to V6. We're going to learn about the placement of those leads later on, no? Later in your medical school journey. But what is the output of the ECG? You're going to have this output. Okay? And this corresponds to the P wave, which corresponds to the atrial depolarization, the QRS complex, which corresponds to the ventricular depolarization, and lastly, the T wave, which corresponds to ventricular repolarization. Next, let's review the different physiology concepts in cardiology. So, if you would remember, the mean arterial pressure is the product of the cardiac output times the total peripheral resistance. So, for example, if you are vasoconstricted, meaning nakasara yung mga blood vessels mo, then mas matataas yung total peripheral resistance, tataas yung BP mo. Diba? Paano naman? How about the cardiac output? The cardiac output is heart rate times stroke volume. Aside from that, cardiac output is a factor of preload, contractility, and afterload. Okay. So, let's clarify some terms. The cardiac output is the volume of blood ejected from the ventricle per minute. So, ilan yung volume ng dugo na lumalabas kada tibok ng puso or kada minuto. While stroke volume is the volume of blood ejected for each heartbeat. So, yung volume ng dugo na lumalabas sa puso kada tibok. Diba? So, yung stroke volume, kada tibok, yung cardiac output, kada minuto. Kaya pag minultiply mo yung heart rate sa stroke volume, you get the cardiac output. Okay, so it says here, cardiac output depends on preload, contractility, and afterload. What are those terms? Preload is the stretch of the cardiac muscle before contraction, while contractility is the ability of the cardiac muscle to shorten. And lastly, afterload is the resistance against which the ventricles contract. So, these are factors occurring before, during, and after contraction. Next, let's describe how to assess the jugular venous pressure and the arterial pulse. Okay? So in the jugular venous pressure, the best way to assess that is by examining the internal jugular vein. Take note, not the external, but the internal jugular vein. By the way, for both of these procedures, you ask the patient to lie down supine, and they should be reclining 30 degrees. Okay? So here, the angle here should be around 30 degrees. So for the jugular venous pressure, you assess the point of maximal impulse. And don't confuse the jugular vein from the carotid artery. So the direction of impulse of the jugular vein during the X descent is inward, while the carotid impulse is outward. Okay. So the internal jugular vein is a surrogate of the pressure at the right atrium. It's also equal to the capillary wedge pressure. Okay. So the patient is lying down, diba? 30 degrees. Tapos, you identify the point of maximal impulse. Then, you measure using a horizontal card and a vertical ruler. So, the vertical ruler corresponds to the sternum. So, yung measure mo kung gaano siya kataas relative sa heart, no? Or sa sternal angle. So, dapat ang normal should be less than 3 centimeters. Kapag more than 3 centimeters, it is indicative of conditions such as right-sided heart failure, fluid overload, for example, in the case of heart failure, as well as pulmonary hypertension. Okay. Tapos, yung movement kasi ng jugular venous pressure is, meron siyang A wave right before his systole, followed by the X descent, and then during mid-diastole, nag-i-increase ulit siya to form the V wave, and then followed by the Y descent. Yan. Review na lang natin yung physiology. Okay? And then, not to be confused with the JVP is the carotid pulse. Yung carotid pulse naman, may mapapalpate dito, no? Just anterior to the, and just medial to the sternocleidomastoid. Okay? So, you palpate for it around the level of the cricoid cartilage. And take note that you should avoid palpating at the carotid sinus kasi baka bigla na mahimatayin yung pasyente. And also, take note na dapat isa-isa lang side yung pagpalpate ng carotid artery. Kasi pag both, baka mahimatay yung pasyente. Okay? So what other things you note in the carotid pulse? Note its amplitude. So dapat yung upstroke should be brisk and it should follow S1 before S2. Okay? And should also note the contour. During history taking, here are the common cardiac symptoms. So pag ito narinig nyo during your history taking, most likely, cardiac yung problema. First of course is chest pain. Of course, there are many different types of chest pain. But cardiac chest pain is described as heaviness or squeezing. Parang dinadaganan or parang pinipiga. Next of course is palpitations. Normally, you should not be that aware of your heartbeat, di ba? Pero with palpitations, parang mabilis yung tibok ng puso, parang tumatakbo, parang kumakaripas, or parang kumakabog ang dibdib. No? Those are the terms that are related to palpitations. Next would be shortness of breath, especially when it happens relative to exertion. Naglakad lang ng konti, pero hingal na. What's that? That's dyspnea. There's also another term. Kapag nakahiga, parang nalulunod. That's orthopnea. And there's paroxysmal nocturnal dyspnea. In other words, kapag gabi, kapag humihiga, pag patulog na, hindi makatulog. Kasi parang nalulunod, kaya ang ginagawa, kailangang taasan yung unan. So, that's called paroxysmal nocturnal dyspnea. And kapag kailangan magdagdag ng unan para makatulog, para makahinga ng tama, that's called orthopnea, specifically 3P low orthopnea. Kapag kailangan ng 3 unan para lang makahiga at makahinga ng tama. Of course, there's also swelling or fluid accumulation called edema. Yung cardiac edema, ang characteristic niya, it starts from baba, from the legs, proceeding upwards. So, there's ascending edema. And lastly, fainting or syncope. Let's look closer to chest pain. So, the classic symptom is called classic angina pectoris. So, this happens after exertion. So, maglakad lang ng malapit, no? So, the feeling is pressure or discomfort. So, parang dinadaganan, parang iniipit. Where? Of course, it could happen in the chest, obviously, but there may also be referred pain. It could also be felt in the shoulders, back, neck, or arm. So this is a key symptom of coronary heart disease. However, take note that among women, especially those over 65, so elderly women, they may report atypical symptoms. So instead of the classic squeezing or heaviness, they could report upper back or neck, jaw, pain, shortness of breath, nausea, and fatigue. This is already indicative of coronary syndrome. So we should not neglect the complaints of elderly women. And lastly, we have to rule out, whenever we encounter a patient with chest pain, we should rule out life-threatening emergency conditions. So for example, myocardial infarction, dissecting aortic aneurysm, as well as pulmonary emboli. So how are we going to promote cardiovascular health for our patients? So the challenge with cardiovascular disease is that many of the risk factors are modifiable. However, it's long-term, so there is a long period of latency. So the decisions that you make today could determine whether in 20 years' time you're going to have cardiovascular disease. So yung mga kinakain mo ngayon, kung nag-exercise ka ba today, yun yung magde-determine kung in 20 years' time, kapag matanda ka na, atakihin ka ba sa puso o hindi. No? So health promotion should focus on screening, identifying risk, and fostering lifestyle changes. In fact, in 2020, the American Health Association came up with a definition of ideal cardiovascular health. So there, they said that ideally, if you are ideally healthy, in terms of cardiovascular health, you should have no cardiovascular disease, of course. So hindi ka pa inatake sa puso, halimbawa, and you have these 4 behavioral factors and these 3 other factors. So for a total of 7. In other words, you should not be smoking, you should have a healthy diet, good physical activity or adequate physical activity, and a normal body mass index. Aside from that, these laboratory factors should be within normal. Your untreated cholesterol should be less than 200, untreated blood pressure should be less than 120/80, and your fasting glucose should be less than 100. So if you satisfy all of these, then you are ideally healthy in terms of cardiovascular health. However, take note that only very few US adults meet all of these 7 criteria, and including Filipino patients. I'm sure there are only very few who meet all of these criteria. Because of this, we need to have widespread preventive efforts, both primary prevention as well as secondary prevention. So how do you screen for the risk of cardiovascular disease? There are 3 steps. Step 1, global risk factors. Step 2, 10-year and lifetime risk. And lastly, tracking of individual risk factors. So for step 1, you do it starting at the age of 20 years old. You ask for individual risk factors such as smoking, diet, physical inactivity, obesity, hypertension, dyslipidemia, diabetes, and a family history of premature CVD. Next, for those aged 40 to 79, you could use an online risk calculator from the ACC and AHA to quantify the 10-year and lifetime risk for a cardiovascular event. And lastly, of course, you need to continuously monitor these risk factors. So ito yung mga tatanong mo during the patient's follow-up. What's the cornerstone of managing these cardiovascular risk factors? Of course, it's lifestyle medication. However, lifestyle medication is very difficult to achieve. So most of the time, you're going to need pharmacologic therapy as well. And we're going to learn about that in your pharmacology lectures. But let's look at this. What should you do if a patient has hypertension? Of course, you need to screen at every visit. The goal is often to be less than 140/90. That's still the long-standing definition of hypertension. You know what? The definition of hypertension changes almost year to year. Just kung ano na lang maabutan nyo sa clinical rotations, yun na lang sundin ninyo, no? Okay, but it's usually less than 140/90. And you need to promote low sodium diet, exercise, and moderate alcohol intake. For men, it's 1 drink per day. For women, for men, it's 2 drinks per day, and for women, it's 1 drink per day. Okay, next. Diabetes, you should screen based on risk factors at age 45. The mere presence of diabetes increases your cardiovascular disease risk 2 times, twofold. So kaya nga, di ba pag may diabetes ka na, automatic naka-statin ka dapat agad. Okay, so how are you going to control blood sugar? With diet, exercise, as well as medication. And lastly, dyslipidemias. Should screen based on age and risk. Statin therapy is recommended for high-risk groups. and emphasize healthy fats and limit saturated or trans fats. You're going to learn about the proper step-by-step technique of doing the physical examination using the videos I have provided in your Moodle. However, take note of the following things. These are just to emphasize some of the more important things that you need to note. So for example, what will you palpate for during the cardiovascular exam? You're palpating actually for the PMI, also known as the point of maximal impulse. You should be able to assess its location and also note its diameter. The normal diameter should be less than 2.5 centimeters. Otherwise, it may indicate ventricular hypertrophy. Also, take note of its amplitude. It should be brisk or tapping. And its duration, overall duration, should be around the first 2/3 of systole. Okay? So you should be able to pinpoint the actual location of the point of maximal impulse using your finger. Next, which part of the stethoscope will you use? Actually, you're going to use both the bell as well as the diaphragm. Take note that when you're using the diaphragm, you apply firm pressure. Use your entire hand. Okay, so you use your diaphragm to listen for high-pitched sounds such as S1 and S2, as well as the sounds of aortic and mitral regurgitation. In contrast, use the bell and you just use a light pressure to listen for low-pitched sounds such as S3 and S4, as well as mitral stenosis. Now, you could perform special maneuvers in order to better hear certain sounds. So, for example, we have two here, and we also have two in the next slide. So, in this slide, we have left lateral decubitus as well as sitting up and leaning forward. You use the left lateral decubitus position to bring the apex closer to the surface. Because of that, remember, ano nga ulit yung valve na nagtatransmit ng sounds towards the apex? It's the mitral valve. So, you could use this position to listen better for the mitral stenosis as well as any left-sided S3 or S4, the extra heart sounds. This other position, sitting up and leaning forward during exhalation, brings the aortic valve closer. You use it to listen for aortic regurgitation. And lastly, we have these special maneuvers, squatting and standing, as well as Valsalva. So when we say Valsalva, it's just breathing against a closed glottis. So parang umiire. So how do you instruct the patient? So pigil nga po ng hininga and umire na parang dumudumi. That's Valsalva. Alright. So these two conditions cause a change in hemodynamic conditions. These two maneuvers. So for example, when you're standing up, that's going to cause a lower blood pressure and a lower overall blood flow to the ventricles, right? Or overall volume of blood that's in the ventricles. Okay, and the opposite is true for squatting. In squatting, you have increased venous return because it's working less against gravity, yung blood natin. Alright? So, what's the use of these two maneuvers? They're useful in differentiating between the murmur of hypertrophic cardiomyopathy as well as mitral valve prolapse versus aortic stenosis. Okay? So all of these are systolic murmurs. So what will happen? So if you have a murmur of hypertrophic cardiomyopathy, if you ask the patient to stand up, that's going to lead to a higher or a more intense murmur. The opposite is true for aortic stenosis. Right? That's it. That's just our lecture for the cardiovascular physical examination. If you have any questions, just message me. Thank you very much, everyone.